Good morning. Welcome to another interesting session of Quest today morning. Today's session will be taken by Dr. Tom George on advanced pinhole treatment of thyroid nodules. Will be moderated by Dr. Anulekha. Inviting dear Father Achan for the prayer.
Shall we all stand for the prayer, please? In the name of the Father, Son, and the Holy Spirit. Amen. Our gracious Heavenly Father, thank you for yet another Thursday in our life. This is the first Thursday of August 2023. We are grateful for bringing us together in this fashion. Again, we are going to hear something very new and something very practical, something very helpful for our dear brothers and sisters, those who come here as patients. We pray for Dr. Anulekha and Dr. Tom, that your unction of your Spirit may rest upon them, so that what all they speak, that we'll be able to understand it and also will be able to implement it, that will be beneficial for others. We thank you for all those who have come here and those who are on the way. Bring us together and also give us a beautiful time spending here. We thank you for answering our prayers. In Jesus' mighty name we pray. Amen. Please be seated.
Good morning and welcome. We know that in today's world, we are progressing from bigger gadgets to smaller and smaller machines, gadgets, and devices. So the field of medicine is not an exception. And from the days where we required many days of hospital stay for surgeries, we are moving on to minimally invasive surgeries and even daycare procedures. World over, even thyroidectomies have become more of a daycare procedure. So today we have something special, whom none other than our very dynamic interventional radiologist, Dr. Tom George, is going to speak about some kind of a pinhole therapy in thyroid disease. Over to Tom.
Good morning all. Thank you, dear Anulekha madam, for your kind words. Thank you, dear Quest team, for giving me another opportunity to deliver a talk. So, you've all come here to get to know about the pinhole treatment. So what is new? There's something new in the treatment of thyroid nodules. So before we begin, let's see what are these pinhole treatments. Okay, so pinhole treatments are essentially very minimally invasive procedures. So these are non-scalpel, scarless and sutureless techniques, which may be done under local anesthesia. They may be, in certain cases, they may be life-saving or some bailout procedures, especially in some cases where the medical or surgical treatment may not be possible, possibly in a very risky situation, etc., etc. So at the beginning of the talk, we'll just make a point clear that this is not a discussion to say one treatment is better than the other treatment or something. Basically, the intention is to inform our patients all the options are available. And let the patient and the treating physician choose the best treatment for the patient, so that the patient, she or he, gets the best outcome. Yeah. So due to the lack of time, we will not be covering the interventional radiology treatment in case of thyroid cancers, and we will be sticking into the benign thyroid nodules, and we will not be covering the thyroid artery embolization in large multinodular goiters. So the thyroid nodules, it's very common. For example, considering the strength of the talk in the amphitheater, if you do an ultrasound neck for all of you, at least who doesn't have any symptoms, at least 30 to 40 of you will have thyroid nodules. That is the frequency of thyroid nodules. And as you know, the imaging of choice for thyroid, it's an ultrasound. And fortunately, a very small percentage of thyroid nodules are malignant. So coming to the alternative treatment or the treatment, the percutaneous treatment we are discussing, that is a thyroid ablation. So what is thyroid ablation? And what are the other, the common non-surgical treatment methods for treating thyroid nodules? That is, we will be discussing about the benign thyroid nodules. So it can be a simple aspiration. So it may be can be simple aspiration or an ethanol ablation using absolute alcohol, or a thermal ablation. Thermal can be cold or applying heat. So thermal ablation may be, the application of heat may be using an RFA or a microwave or a high intensity focused ultrasound or a laser ablation. So what are the indications? Do we need to treat all benign thyroid nodules? It's a controversial matter for discussion. So in general, do we need to treat a benign thyroid nodules, or what are the common indications to treat a benign thyroid nodule? So it may be a cosmetic reason for the patient. It may be the mass, the nodule may be big enough and causing compressive symptoms, or there may be an anxiety or the concern for a malignant change. So the usual ways of treatment, as we know, it is a surgical and a medical treatment. And in general, not all surgeries cause complication, but in general, the concerns in the point of a surgery may be the need to give a general anesthesia or a risk of hypothyroidism, and so the patient might have to be put on thyroxine medications. A risk of hypocalcemia. Yeah, thank you. Hypocalcemia and possibly a longer recovery time and chance of scar formation. So how do you select a patient for ablation? So first of all, we need to prove it is a benign thyroid nodule. So how do you do? So it's FNAC proven. At least 2 FNAC needs to be done and prove it, or a single biopsy core can be done and prove it as a benign thyroid nodule. Because once you prove it as a benign thyroid nodule, from the pathologist's point of view, so if the chances for it to be having a false negative for a thyroid nodule is very low. So, so another concerns, indications like what we told, symptomatic, like if there are cosmetic concerns, the indications to select the patient for ablation, or a compressive symptoms like a difficulty in breathing, difficulty in swallowing, voice change, etc. So ablation, as we know, it is increasing popularity because of the minimally invasive techniques, and there are various attractive advantages of the percutaneous treatment over the usual other treatment modalities. So what is, from the patient point of view, why is undergoing the treatment for thyroid nodule? Because of the mass, because of the disfigurement. So the size reduces, and he or she gets the results what he wants. There is reduction in thyroid nodule. There is reduction in the nodule-related symptoms. We'll be coming to the details soon. And the more importantly, there will be preserved thyroid functions. Because we are essentially not going and dealing anything with the normal thyroid parenchyma. So we are just ablating or treating the concerned thyroid nodule. So thyroid functions are preserved. So it's now the pre-procedure evaluation. It's not like you see a thyroid nodule, a patient goes for like surgery or ablation or treatment. There is proper evaluation which has to be done. So first of all, like I told, we need to prove it is benign. Then we assess the ultrasound features of the thyroid nodule and volume. Assess that there is a symptom score, there is a cosmetic score depending on whether the size is, the mass is seen, whether it is palpable, etc., etc. And do the necessary lab test. Then in appropriate setting, patient might need to undergo a CT MRI in certain cases, or if it is a autonomously functioning thyroid nodule, he or she might need to do a thyroid scan or technician scan. So there are specific strict guidelines, especially in the Korean side, because they are very much into thyroid ablations. So, and like I told, do we need 2 FNACs or biopsies for all patients? It is not strictly not 2, because if there is clear-cut ultrasound findings suggesting a benign thyroid nodule, even a single FNAC or a core needle biopsy should suffice. And if it's a autonomously functioning thyroid nodule like AFTN, a single FNAC should suffice to prove it benign and proceed for the procedure. And this is the Bethesda system, which our surgeons and pathologists will be well aware of. So all of you. So basically, this is the categories of cytopathology in thyroid FNAC. So what we will be interested is in the category 2. That is a benign thyroid nodule, where usually a surgery may be avoided. Because, and we are discussing pertaining to the thyroid nodule, benign thyroid nodules. Okay. So these are the Korean journals which are showing the various guidelines for core needle biopsies. And like I already told you, what are the advantages of minimally invasive treatments of thyroid nodules? Thyroid function is not affected because only the abnormal thyroid gland or the nodule is targeted. It's a scarless and sutureless procedure. Patient can be discharged even the same day or next day. And few complications which can be seen, maybe patient can have some mild pain, which is usually transient. If especially the lesion is located very close to recurrent laryngeal nerve, there may be, if accidentally, there may be voice change which can be transient. That also we can completely avoid if you're very careful. As usual, there may be small risk of bleeding and nerve compression and small chance of nodule rupture. So initially coming to the cystic thyroid nodules, that is, if there is only less than 10% of solid component in the cystic nodule, usually the first treatment modality is ethanol ablation. And if there is more than 50% solid nodule, we will go to the thermal ablation, which is the preferred modality. And this is the pre-procedure evaluation for an ethanol ablation. So this is just a small video showing the patient with a cystic thyroid nodule. You can see this is cyst in the nodule is completely cystic. So we do an ultrasound showing the complete cystic nature of the thyroid nodule. Do a Doppler, seeing whether there is any significant vascularity. Make sure there is no major vessels. And you can see the zoomed image. You can see the needle coming here. So you can see the needle inside. We aspirate out initially we aspirate out the entire contents of the cystic lesion. You can see slowly the size of the lesion reducing. So once you aspirate out, you assess the volume of the fluid aspirated out. Then you inject the ethanol. That is absolute alcohol. You can see the ethanol being injected. And after injecting, after a specific indwelling at a time, you withdraw the absolute alcohol outside. And this is post-ethanol injection. You can see the contents inside. So how are the results? So this patient, the volume of the cystic nodule was around 38 cc prior to ablation. And 1 month follow-up, you can see there's just 7 cc. So almost 80% of the nodule has gone. So essentially the patient, whatever the huge nodule was there, that is almost absent. That it will not be seen outside. So almost 80% improvement just in the 1 month follow. And so this is what we are telling about the ethanol ablation. And there is a lot of literature available. So in general, around 85 to 98% reduction in volume happens in ethanol ablation. Now coming to the thermal ablation, that is RFA or microwave ablation. So similarly, you have to do a proper pre-procedure evaluation. So do an ultrasound, get a cytology or histopathology confirmation to prove it is benign, and do an adequate coagulation profile prior to procedure. Do a thyroid function test. Patient has to consult an endocrinologist and do the adequate evaluation. And procedure is essentially done under daycare admission under local anesthesia. Initially about the radiofrequency ablation, as you know, there will be an external radiofrequency generator, and by means of alternating electric field, thermal energy is used to ablate the thyroid nodule, and basically we achieve tissue necrosis. It can be done by various techniques, either a fixed electrode procedure or a moving shot techniques. Basically, you can see in this figure, like you can see that nodule is marked 1, 2, 3, 4, 5, 6, 7. So the needle goes and ablates, comes back, ablates this area. Similarly, you ablate the entire nodule. That is how you achieve complete necrosis. There is a moving shot technique. Similarly, there is a microwave ablation method. That is the technique is slightly different, but the principle is same, the thermal energy. And it's slightly newer technology in RFA, and supposedly the heat sink effect is slightly lesser, and the procedure duration also can be reduced. So this is how procedure is done, percutaneous treatment, that is ablation technique. The doctor, the intervention radiologist sits behind the patient. This is, you can see the generator, the electrode being kept, the patient patient is positioned this way. So essentially, it's done under local anesthesia. So the patient and the doctor speaks. If the patient has any discomfort, patient can directly tell to the doctor, because it's throughout patient is awake. And there is different techniques to avoid vascular or nerve injuries. This is called hydrodissection, whereby we create a fluid space between the major vessels. And this is a nodule, this is a vessels and nerve. So we create a fluid space and ablate the lesion with a good result. Similarly, like the moving shot technique, like I told, there are different major structures which you need to be very much aware, avoiding injury to these structures. And again, the hydrodissection, depending on the nodule location, this blue color thing is the fluid being injected inside. And this shape, as you all know, this is the thyroid nodule, thyroid gland. This rounded one is a nodule. There's the vessels nearby. So this blue color thing is, from outside we inject fluid and create a space between the nodule and the major structures. Again, the technique of ablating. So you can go through this is the isthmus of the thyroid gland. Isthmus, and you can even ablate directly in the nodule. Different techniques. There's a transsystemic and a lateral approach. Yeah. So again, can I have a mic? Yeah. Yeah. So again, so this is a different technique. Like I told you, the moving shot technique. So once you ablate, this is how you see. This is a bright echogenic area along the way you ablate. So after the entire nodule is ablated, you will see a complete bright area that is echogenic contents, thereby showing adequacy on table adequacy of the complete ablation. And not even a single step is done blind. It is each point the needle tip is seen well on ultrasound, so that it is 100% safe. And again, like I told, the anatomy and approach, you need to be very much aware of the anatomy and the approach, because there are essentially major nerves and vessels all around the gland. Yeah. So the transsystemic approach. Okay. Now, how do you evaluate and how do you follow up the patient? So this is basically normal ultrasound with Doppler, and you can even do the procedure pre-procedure. You can inject contrast, like you see. Do a CT and MRI contrast. You can there is something called as an ultrasound contrast. So prior to procedure, you inject contrast. You'll see a good enhancement of the nodule, and on table after ablation you can see there is complete absence of enhancement, which shows complete necrosis, which suggests complete ablation. So this is this is after ablating. You can see the size reduced and the Doppler signals significantly reduced. And after ablation, you call the patient after 1 month, 3, 6 months and 12 months, and that's how you follow up. And this is the formula to calculate the volume reduction ratio, so that you can have the, even the patient also will tell you the size is reduced. You can also objectively calculate the reduced volume size. And there are a number of studies showing RFA and microwave results. In general, post RFA, in 1 month, you usually see around 50 to 55% reduction in volume size. And after 6 months, around 80 to 85% reduction in the nodule size is usually seen. Again, the ultrasound showing the different major structures, moving shot technique. And there will be critical structures like arteries and all, which you have to be well aware prior to the procedure. Again, the guidelines from Korean society. And the articles to substantiate the ablation technique, RFA and microwave, in comparing with the surgery and all. There are multiple articles showing the benefits of thyroid ablation. So, and actually the indications for thyroid ablation have extended even to malignancies and in autonomously functioning thyroid nodules or toxic nodules. Especially in recurrent thyroid carcinomas, when a surgical option may not be always possible, and we may not be able to give a cure for the patient, but the bulk of the nodule can be reduced post-surgery in recurrence cases, thereby patient symptoms may be alleviated. And in some cases of autonomously functioning thyroid nodule, patient may not be always suitable for surgery or radioiodine therapy, and especially in elderly patients who have other chronic disorders, after you do a surgery or a radioactive iodine therapy, patients can have other complications because of the already existing chronic disorders. So in that case also, ablation may be, or a minimally invasive intervention radiology treatment may be an option. So this is another article showing a role of RFA for AFT, that is a autonomously functioning thyroid nodule. So they took around 44 patients from different institutions, and they followed up the patients, and post-ablation, around 75% of reduction in size happened after 6 months, and with improvement in the thyroid functions. This is in case of autonomously functioning thyroid nodule. And again, there are studies comparing the thyroid, benign thyroid nodules, comparing the surgery with radiofrequency ablation. So this is, in this study, they took around 200 patients, around 15 to 16 month study. 200 patients underwent surgery, 200 patients underwent ablation. And so essentially the results were very good, and in the complications which were seen in surgery were far less higher. Means in the patients who have taken up for radiofrequency ablations, there were almost no complications in comparison to surgery, and essentially the hospital admission stay, everything was very short in case of RFA. Like I told, it can be done as a daycare or a single day admission procedure. This is other article substantiating the role of RFA ablations, microwave versus RFA, which is better, or both against versus the surgery, or what is the role of microwave ablation, and so and so. And this is other article. This is a recent article. This is a couple of months back published in American Journal. So basically, in this particular study, they took elderly patients, that is above 60 years, whether they should go for a surgery in a benign thyroid nodule or whether they should go for a ablation. So as I already told, whatever complications which were seen in surgery were not seen in ablation patients. And the conclusion of the study was radiofrequency ablation could be considered as a first-line treatment, especially for elderly patients with benign thyroid nodules. This is another case I've taken from the journal. So basically, this is just to show you how the thyroid nodule real-time results appear. So this is a proven benign nodule, well-defined lesion. And like I told you, the ultrasound contrast, this is how it appears after giving ultrasound contrast on table prior to ablation. And see, you can see this is all bright color thing. So this is all enhanced ablation. You can see the nodule completely brightened up. Immediately on table after ablation, see the black color is showing complete ablation, complete necrosis of the enhancement. And then after 1 month follow-up, where the size has already started reducing, still there is complete lack of enhancement, which shows successful treatment. This is after 1 year. You can essentially see the nodule is not even seen with a minimal scar tissue. That's all, inside the lesion. So that is the follow-up of the thyroid nodule. So same way, this indication can be even extended to a parathyroid gland. As we know, parathyroid gland and thyroid gland are very closely situated. There are 4 small nodules, like glands, which are parathyroid gland, which is situated in proximity to the thyroid behind. So this and so the same similarly, like we saw in thyroid nodules, this ablation technique can be extended to even parathyroid adenomas, especially in patients who are poor candidates for surgery, or who are critically ill patients for whom we can offer ablation. So this is our own case. Some of us may already know. So basically, a 78-year-old lady who had come to ER with hepatic encephalopathy. The patient had altered sensorium, and patient presented with hypercalcemia, the symptoms of hypercalcemia, and there was a past history of surgery, major surgery, and failed surgery, and there were multiple comorbidities for this patient, like poorly controlled asthma, diabetic, Parkinson's disease, etc., etc. And so patient was disoriented at the time of presentation. After the ER consultation, our medical endocrinology team took over, and patient was admitted under Dr. 𝗵𝗵. And after the medical management, the patient's calcium levels and the symptoms could be alleviated very much, and the calcium levels we could bring down to almost normal level. So, but the problem with the medical treatment is we cannot put the patient lifelong on medical management because of the some issues with the medical treatment, as well as about the expense part. So the patient improved very much within few days, and after then we got an ultrasound neck done, because what was the cause for this hypercalcemia we need to know. So ultrasound showed there is a well-defined, I'm not going into the details of the ultrasound findings. Basically, there was a small nodule in the neck, and we got a CT evaluation done, which showed the arrow, you can see it points to the nodule, which is an enhancing lesion, which in the current clinical setting corresponded to a parathyroid adenoma. So it was a case of parathyroid adenoma. So now this is a nuclear scan which confirmed the findings. So now, how do you treat the patient? So like I already told, the usual treatment methods, what we know is a medical treatment and a surgical treatment. So now, there is something called as, like we already saw, there is a option of ablation or a minimally invasive treatment for the patient. So we discussed all the options with the patient, and then the patient, as in not a patient, we were not in a point to discuss the patient, but the patient relatives. And so the options other than medical management were surgery and a intervention radiology treatment option. So now, finally, the patient relatives opted for a minimally invasive intervention radiology treatment. So why did they opt for it? So basically what we feel is because of the underlying comorbidities, there was a risk of anesthesia-related complications. Patient gave a prior history, like we saw prior history of failed surgery. So they were all the more anxious and concerned whether to go for surgery. And we told the procedure could be done under local anesthesia, which was very much attracting for them. And patient will have a faster recovery and hence shorter stay. And we planned for radiofrequency ablation for the patient. This is on the day of the procedure. You can see the patient lying down and myself behind. So during the procedure, and procedure we could do just under local anesthesia. The ultrasound, under ultrasound we could target the lesion, and following ablation, like I showed you before, the good bright echogenic cloud formation could be seen, and procedure could be completed in just less than 20 seconds. And this is usually how you approach in a parathyroid adenoma. The adenoma is basically a nodule very closely related to thyroid. So you can either approach directly into the nodule if it's a big nodule, or if you can approach it through the thyroid gland. Yeah. So how were the blood reports prior and post procedure? So prior to procedure, as you can see, the parathyroid hormone level was 321, which is very much higher than the normal levels. And immediately on, like after you do a parathyroid surgery, within 30 minutes the levels reduced to 50%, and in one day it came to 54.9. That is within the normal limits post ablation. That is how the actual results are seen exactly after surgery. Yeah, so that is the level of improvement of parathyroid hormone level. Calcium levels prior to procedure was in the normal range because the patient is already under medical management and the calcium levels were corrected. Even that was also within normal limits after from one day, and we could stop the calcium, that is a cinacalcet. The calcium medications could be stopped. Now patient could be discharged on day 2. Day 2 is because patient was already on many other comorbidities. Otherwise we would have immediately discharged the patient. And so this is the patient's neck immediately after the procedure. This is the dressing removed. Next day of the procedure, you cannot find even a small scar. This is how it's the beauty of the ablation treatment. So that is the same thing as you will see post thyroid ablation. Yeah. So yeah. So again, follow up. This last July is when we did the procedure. Now it's almost more than a year. So the patient is on regular follow up under our endocrinology team, and many other departments are seeing her. So this is the parathyroid hormone level prior to procedure, 321. At 1 month, 64. At 2 months, 50 within normal limits. Even almost at 10 months, or like latest report is 55. So that is within the normal limits. So basically, essentially, we have it's a complete cure of the disease, which is being persisting at the end of 1 year. Again, the levels for you. So what is the response from the patient point of view? The dementia and the tremors have improved. General condition has remarkably improved. Patient, as we already saw, the patient came in encephalopathy. Patient had a lot of comorbidities. Patient is able to take a shower on her own and even helps in cooking, which is very much great from the patient point of view. And most importantly, there were no episodes of hypocalcemia. So patient need not have to be. We don't have to give any calcium supplements. Yeah, and to conclude today's discussion. So ablation is a safe and effective alternative to surgery for treating benign, non-functioning or autonomously functioning thyroid nodules. However, knowledge of ultrasound-based neck anatomy and its significance is essential for a safe and effective ultrasound-guided procedure, and proper planning and pre-ablation evaluation is necessary for complete ablation. And this is the take-home point for today about the minimally invasive treatments or intervention radiology treatments. They preserve thyroid function. There is fewer complications than surgery. There is patient symptoms improve, and cosmetic appearance significantly improves. It can be done as a day care treatment and done even under local anesthesia. So this is another real-time case which I have taken from another article. Thyroid neck bulging, 42-year-old patient with significant neck bulging because of the benign thyroid nodule. This is post-treatment. After 6 months, you can see there is absolutely no scar and significant improvement in the cosmetic score. Thank you.
Thank you, Dr. Tom. We have seen that 78-year-old lady and how drastically she improved, and it was really beautiful to see that. Dr. Tom is open for any questions.
How do you rule out malignancy in a sub-centimeter thyroid nodule? You often say that you cannot do an FNAC ultrasound guided. Secondly, parathyroid carcinoma, how do you rule out?
Sir, sub-centimeter, most of them might reject. The usual sizes of thyroid nodule, what I get for FNAC is 4 millimeter and 5 millimeter. So there are people who tell they may not be able to do, but that is like thyroid's staging and categorization is basically if there is a definite concern for thyroid's category, and if an FNAC can be done, definitely FNAC is done.
Thyroid's 3.
Okay. Thyroid's 3 and
FNAC. 6 millimeter nodule.
Yeah, if it is an FNAC done and the pathologist says there is adequate cellularity and it is benign.
Cannot do.
Sir?
I cannot do an FNAC. That is the answer that we usually get from radiology.
Okay, sir. Like what I was telling you is like whatever referrals I am getting, you and I have done FNACs for 5 millimeter. But let's say, like sir, you told if you cannot do an FNAC, there is no point. Like the whole discussion was like if you have to prove it is a benign nodule. If it is a benign nodule, we cannot prove. Then probably if it's a surgical candidate, definitely surgery should be offered. It's only the patients where you prove it as a benign nodule, that too at least 2 sessions, then only we can prove. Otherwise, it's a proper benign nodule on ultrasound findings and a single tissue you get, then definitely you can go for an ablation.
And parathyroid carcinoma, how do you rule it out?
Sir, again, that is essentially a imaging finding. That is what we told. If the patient is a poor candidate for surgery, critically ill, if the surgeon is worried about any other complication or the anesthetist is worried, then this is also in an adenoma what we do. If it is if a surgical risk are there, probably we might go for an ablation.
How do you know it's an adenoma? You can only in histopathology you can know whether it's an adenoma.
Yes, sir.
You have to see the capsular and vascular invasion.
Yes, sir. Yes.
So then how do you decide?
Sir, if the patient is not a surgical candidate, if there is a critically ill, or if you would even damage the patient's life with the surgery, that is when we go for an ablation. Because compared to thyroid, parathyroid gland ablation, the rarity of the procedure is also very much. We were fortunate enough to get a patient for parathyroid ablation because unlike thyroid ablation, the parathyroid ablation, the chances are, the cases done are relatively less. Recently, I had gone for a workshop in Delhi where they do thyroid ablation, like almost 20 ablations per month. That is almost 1 case per day. So that is the volume, and that is the popularity for the thyroid ablation. It is coming out. So that is a new upcoming field, but for parathyroid ablation, we are yet to get a proper guidelines.
See, surgical department has got a record number of 1,200 surgeries done.
Yes, sir.
We rarely get a complication. As you have mentioned, all the complications of surgery, not even 0.1%.
Okay.
So I don't think that's a very, very, very difficult one. 2, what do you do for a follicular neoplasm then?
Sir, this is essentially for a benign. Yeah, so this is essentially for a benign thyroid nodule. For follicular neoplasm, we usually don't.
So I think in a follicular neoplasm, we will refer for surgery. There's no doubt about it. The only question comes if it's a proven benign nodule, if it's a if it's a TBSR-TC2, and we are sure it's a benign nodule and it's very large enough and the patient is not very keen for surgery. In that case, probably we would refer. And the second question to answer Dr. 𝗔𝗱𝘃𝗃 question is about parathyroid carcinomas. Actually, if you were to see the number of parathyroid adenomas we've seen, for about 100 or 200 adenomas, we have only seen one carcinoma. In the entire years I was in Vellore, we saw only one parathyroid carcinoma. Yes, that is one. Second thing is, if sometimes we have to palpate. Once we had a patient who came like a thyroid nodule. A calcium was not done. When we happened to do a calcium pre-operatively, it came as 15. And that was a palpable thyroid nodule. So if you have a palpable parathyroid adenoma, that is a clue that it may be a carcinoma. Second thing is, of course, only on biopsy, you will find that it will have vascular and capsular innervation. Finally, on the other thing we have found is has vascular and capsular innervation. What you see on histopathology, it will be there. Recently, we had a patient who came with a calcium to the emergency with 20. More than 20 was a calcium hypercalcemic crisis, altered sensorium. That patient we suspected, because when you see very high calcium values and the parathyroid hormone was more than 2000. In an extremely high calcium value with very high PTH values, we suspected parathyroid carcinoma. In fact, Dr. Anish Sugunan, I don't know if he's here, he went in prepared to do an en bloc resection if required. Fortunately, it was a giant parathyroid adenoma. It was not a parathyroid carcinoma. Yes, sir.
The relative of you comes with a nodule. What will you do? Surgery, refer to surgery, or?
Many of the patients, actually we have sent very few patients to Dr. Tom for thyroid nodule ablation, partly because most patients prefer to be on follow-up. Even if there is like less than 1 centimeter, as you said, we can't FNA, and many of our radiologists mention that it's very difficult. You may only get blood. In that case, the American College of Radiology mentions that you can keep them on follow-up. So many of our thyroid nodules on follow-up, and many of them, I don't know, maybe do the prayers and everything, the nodule shrinks also. So you don't have to offer a surgery. I think only when the pressure effects come, we refer them to surgery, or if they are refusing surgery, like this lady with the parathyroid, she didn't want surgery, she had a failed surgery. So that is when we took the opinion of Dr. Tom, and she had an excellent outcome. I think both have got excellent outcome. I think predominantly the role is still surgeons, but I think whenever there's a cosmetic issue and so many other factors, we decide.
We appreciate all the efforts done by Dr. Tom. We are not putting you down anyway.
Actually, this parathyroid case, sir, you had seen first. And actually the main reason that patient had too many medical complications. The anesthesia, the ASA grade was very high. So we involved, and we had a team meeting, and finally we decided we were going for the innovation.
Yes, well done.
Thank you, sir.
Dr. Anish?
Good morning. For thyroid nodule ablation, do you keep any cutoff with the size of the nodule?
Yeah, thank you. That is a good question actually. So basically, thyroid nodule, usually above 5 centimeters, we may not be able to do in a single session. So, and like for ablation also, because larger lesions will take longer time for ablation. So around 20 minutes ablation, if it is taking more than that, so we might actually do it as a staged procedure. So we do a single session. Otherwise, there is no cutoff for the nodule, because essentially we can repeat the procedure and follow up, the size reduces, and the remaining enhancing area you can see, and then you can target that, and then you can reduce the size.
Also, any precautions in lesions which are close to the RL, and like there should be a 3 millimeter, 4 millimeter gap between the tracheoesophageal groove or something like that, close to the capsule or something?
Yeah. So essentially, we need, like I told you, adequate hydrodissection can be done. And what we have, what the literature says is basically there will be some area of the thyroid nodule which will be very close to RLN. So even if you spare that area, in the follow-up, what happens is nodule shrinks. So then you'll get a better, safer window. In the second session, you can ablate it. Or if you can give a good hydrodissection in the initial time itself, between the nerve and the capsule, that is good enough, you can do it. Or like both ways you can do.
Thank you.
Tom, thank you. Thank you very much for taking us through that. It's very interesting the way we evolved. So I remember at his first interview, we took him as a GI interventional radiologist. I remember John Walliams asking him, why don't you look at other areas as well. And that was the first time we started thinking about it. So thank you, Tom, for going through and getting us into all this. So congratulations. Thanks for your presentation. I want to introduce 8 new members of our faculty who've just joining us today. So I'll start with Dr. 𝗔𝗱𝘃𝗃, Professor, HOD Orthopedics, formerly Professor and Head of Orthopedics, BCMCH. If you think Sam is a nice guy, this guy is far, far nicer. Thank you, Vinu. I think many of you in the... Yes, he was your student. He is Dr. O.C. Abraham's younger brother. His parents, you know, all of you know very well, and they are going to come and stay with us. So it's wonderful to have you all. Welcome, Vinu, and your family. CMC gained because of Kottayam Medical College training. So Vinu is the most popular go-to person in orthopedics in CMC. So I'm so glad that you chose to leave that and join us. He had some more years to do in CMC, but on invitation, he has come. Thank you, Vinu. Welcome. There's nothing that he cannot do in orthopedics. The second, Dr. Juliet Johns, Senior Resident Neonatology, did her MBBS Government Medical College, MD from All India Institute of Medical Sciences, Senior Residency in St. John's Medical College, and she's now joining neonatology. She's already trained undergraduates, postgraduates in pediatrics. Welcome, welcome, Juliet. Dr. 𝗍𝗍𝗃 joins as Senior Resident Pulmonology, did her MBBS at GMC Kochi, the DTCD from Trivandrum, and DNV Pulmonology from Cosmopolitan Hospital. Lots of experience, has been handling lots of patients. At the interview, she said, no numbers, no problem. I can handle any. What's the number you see? 100 a day? Something like that. Okay. So, Luke, you've got a gem to help you with the large numbers that you have. Welcome, 𝗍𝗍𝗃. Dr. Stephen K. Punus, born in the campus, part of us here, Senior Resident General Surgery at the moment, MBBS from Karakonam, and got in with a very high rank for the MS Kottayam Medical College, just finished his SRship from Government Medical College, Kottayam. Welcome, Stephen, into the Department of General Surgery. Dr. Anaga, Senior Resident OB-GYN, MBBS from Pariyaram Medical College, DPNB from Edapai Hospital, Malappuram, just finished her SRship in GMC Kannur. Anaga? Yes, she's behind the camera. Dr. Thomas K. Abraham, Senior Resident in Pathology, MBBS from GMC Ernakulam, MD Pathology from CMC Vellore. Thomas, welcome to our midst. Dr. Gauri S. Nair, Senior Resident Forensic Medicine, MBBS from KVG Medical College, Karnataka, MD from JSS Medical College, Karnataka. Gauri in Forensic Medicine. There she is behind you. And Dr. Reem Rachel Roy, MBBS from Amala Institute of Medical Sciences, MD from MGM Hospital, Aurangabad. She's joining the Department of Anesthesiology. Welcome. So this is the welcome to them from the academic fraternity. Yesterday they were welcomed by the worshipping community. Achan led the worship and welcomed them, after which they had a day's induction. So they'll be with you today, and this is going to be the pattern hereafter when new people join us. So we just want all of you to feel part of our family, our community, so that you know, many of you or many others are trying to do. We want to be the best in what we do. We want to do special things which others are not doing for the benefit of the community. And most of you would be happy to hear that the first list was announced yesterday for the MBBS for the batch of 2023. Many children have chosen us over the other private medical colleges. So this is for the first time that this is happening, because you knew, I remember JSK telling me, "Ee 5000 rank ullavarekke enikku thannal njan engane padipikkunnu. Ee prasham athrayum prashnam varthilla." Ketto. of course, the top ones will go to the government medical college. Amongst the privates, we have to be the best. So that if our teaching is very good, if our training is excellent, people will choose to be here. And most importantly, if the mentoring is excellent. So we've done, I think, quite well in terms of our compassionate care. We've done quite well now. The research day that we had showed that we are reasonably good in research. But I think from now on, this year, we're going to focus on not just the teaching, training and mentoring. I would love all of you to help us with that. Dr. Anulekha, thank you so much for leading us in this, and Tom. Thank you all for coming.
Bless the Lord, oh my soul, oh my soul. I worship His holy name. Sing like never before, oh my soul. I worship Your holy name. The sun comes up. It's a new day drawing. It's time to sing.